Good evening and welcome to our program. Tonight, we're going to be discussing evolving strategies for the management of hereditary angioedema, a patient-centered approach with real-world examples. I'm Dr. Maeve O'Connor. I'm clinical assistant professor at the University of North Carolina, Charlotte. I'm also the medical director of integrative allergy and immunology care and the chief medical officer of the Consortium of Independent Immunology Clinics. My disclosures are listed here on the slide, and I am pleased to present our co-presenter, Dr. Christina James. Dr. James?
Hi, I'm Christina James, and I'm a clinical instructor at the University of Washington and practice in Alaska at Peninsula Allergy and Asthma Center.
Thank you, Dr. James. In today's program, we'll be exploring the evolving landscapes in the management of hereditary angioedema, or HAE, with a particular focus on patient-centered strategies and real-world clinical applications. Our learning objectives for this evening are: we're going to apply guideline-recommended strategies to accurately identify patients with hereditary angioedema. We'll analyze and compare approved and emerging treatment options for managing HAE effectively, and we're going to utilize shared decision-making and validated assessment tools in the development of treatment plans for patients with HAE. First, an introduction to hereditary angioedema. So HAE is a rare and potentially life-threatening disorder characterized by unpredictable episodes of swelling. And these episodes of swelling can occur anywhere in the body, typically affecting the skin, GI tract, and the upper airway. It's very important to have timely recognition and appropriate management. These are essential to improving patient outcomes of those with HAE. So the clinical features of HAE are varied. So typically patients will present with recurrent, non-pitting, non-pruritic, subcutaneous, and submucosal swelling. One of the hallmark and cardinal signs is there's no urticaria and no itching. This is really important for the differentiation of HAE from allergic angioedema. As I mentioned, the attacks may involve the extremities, the face, the abdomen, or the airway. And unlike histamine-mediated angioedema, HAE does not respond to antihistamines or steroids. Now, HAE is typically an autosomal dominant disorder. So you have HAE type 1 or 2, and these are characterized by a deficiency in C1 inhibitor or a dysfunction in C1 inhibitor. HAE with normal C1 inhibitor, also known as HAE normal C1, these patients have normal levels and normal function of C1 inhibitor, but the presentation can be identical to HAE type 1 or type 2. So what do the attacks look like? So acute attacks can be variable, and this is what often leads to delay in diagnosis. So the majority of these will develop gradually over hours, and it can be over several hours. The attacks are usually prolonged, and they can peak around 24 hours, and then they usually will resolve over 2 to 4 days, and that can also be variable. So again, as I mentioned, standard treatments for allergic reactions like antihistamines, corticosteroids, and epinephrine do not treat HAE. These treatments will be ineffective. The swelling will persist. And this is a key diagnostic clue if you have a patient in front of you with swelling. Again, these attacks, acute attacks, can be unpredictable and have varying frequency as well as varying triggers. Again, I mentioned the commonly affected areas, and those are listed here for us. I think it's important to know that the face, extremities, and genitals, again, the subcutaneous common sites, can be very disfiguring and very painful, and also a bit embarrassing for these patients. The oropharyngeal swelling can lead to airway obstruction, and this can be potentially life-threatening. And then when you think about the GI tract, swelling of that bowel wall can cause severe abdominal pain, nausea, and vomiting, and can mimic a surgical abdomen. Oftentimes, before a patient gets a true diagnosis of HAE, they may have had multiple exploratory laparotomies to try to find out what's wrong with their abdomen. Onset and trigger. So again, the first symptoms can appear in childhood or adolescence, although we have seen patients even not show symptoms until adulthood. Common triggers can be physical traumas, including minor injuries such as surgery or dental work, or even repetitive work procedures like a jackhammer worker, for example. Emotional stress can also be a trigger. Stress can precipitate attacks in some patients. We all know how important stress management is to our general health, particularly important in HAE patients. And then there are hormonal factors. So estrogens, such as those seen in oral contraceptives or pregnancy, can make symptoms worse, especially in females. Again, it's very important to recognize and minimize known triggers to hopefully minimize the attacks in not only their frequency, but also in their severity. So here's a slide that just reviews the pathogenesis of HAE. So this is a pretty nice schematic. And in this, you can see in the classical complement pathway, the complement protease C1 is activated and then assembles the C3 convertase, as you can see here. And the activation is indicated by horizontal bars over the complement name. So just so you kind of can follow this schematic. In the contact activation pathway, trace amounts of factor 12A activate additional factor 12 as well as pre-kallikrein. Activated factor 12A activates factor 11 to factor 11A, leading to enhanced fibrin formation. And then activated factor 12A and kallikrein activate one another. And then plasma kallikrein cleaves high molecular weight kininogen to release bradykinin. And that's the key. In the fibrinolytic pathway, plasminogen is activated to plasmin, which then cleaves fibrin. And you can see the proteolytic activities there indicated with the green arrows and point towards the step that they're actually catalyzing. The central defect in HAE is a deficiency or dysfunction of C1 esterase inhibitor, or C1, as I will shorten that name throughout the presentation. This central defect leads to uncontrolled activation of the contact system that we just reviewed and increased bradykinin, which is a potent vasodilator responsible for the swelling that these patients present with, again, whether that's subcutaneous or submucosal. It's very important, as I alluded to earlier, to know the difference between mast cell and bradykinin-mediated angioedema. It is key to accurate diagnosis as well as accurate treatment. HAE is bradykinin-mediated, which explains why it doesn't really respond to any of those traditional allergy medications, the antihistamines, the steroids, even epinephrine. So recognizing this distinction can prevent treatment delays, unnecessary interventions, and in the worst case, death. So hereditary angioedema is classified into three main types, as I mentioned earlier. Type 1, which is low C1 inhibitor levels. Type 2, normal levels, but dysfunctional C1 inhibitor. And HAE with normal C1 inhibitor, often associated with mutations in the genes that are listed here. Genes like factor 12, plasminogen, angiopoietin-1, kininogen-1, MyoF, HS3-ST6, and then we know that some patients will still present with hereditary angioedema symptoms classically, and again, they will have normal labs, and we may not know their genetic defect yet. A lot of these genetic defects have actually been identified in very recent years, and this search is still on for more. For the correct diagnosis of HAE, it's very important to know when to suspect it. So HAE should be suspected in patients with recurrent angioedema, right? Especially when it lacks urticaria and itching, doesn't respond to antihistamines or steroids, and can be accompanied by that abdominal pain that I mentioned or upper airway involvement. Importantly, we mentioned that it's autosomal dominant, but about 25% of patients may have no family history at all. So without a family history, some of the other red flags that we've reviewed should prompt further evaluation, such as no urticaria, no itching, not responding to traditional allergy medications. But again, those painful recurrent abdominal symptoms. It's also important to know that prodromal symptoms before swelling are pretty common in patients with HAE. I've had patients say to me, I always know that I'm about to swell because I'll feel a little bit dysphoric, or I'll get a lacy rash on my skin, or I'll just have a sort of feeling of doom. So if a patient tells you that before their swelling attacks that they have some prodrome, HAE should be at the top of your list of diagnosis. So the first line diagnostic approach includes a C4 level, a C1 inhibitor antigenic level, and C1 inhibitor function. If they are abnormal, then you would confirm with repeat testing. So the C4 level is a radial immunodiffusion or turbidimetry or nephelometry. C1 inhibitor is radial immunodiffusion or, again, turbidimetry or nephelometry. C1 inhibitor function is an ELISA or chromogenic assay. Again, if those are abnormal, you'd want to confirm with repeat testing. And then for suspected cases with normal labs, consider genetic testing for HAE with normal C1 inhibitor. Again, I pointed out the genetic mutations that have been identified. So if you find one of those, then you have your diagnosis, but there are still cases where that genetic mutation may not be identifiable as of yet. But the important thing here is that structured workup is critical for the timely diagnosis, appropriate classification, and then appropriate treatment of our patients. So what does a typical diagnostic laboratory profile look like? So here we have an example of what the typical diagnostic profile would look like for HAE1. So C1 inhibitor function, protein level, and C4 would all be low. And for HAE type 2, you could have low C1 inhibitor function, normal or increased C1 inhibitor protein level, as well as a low C4. So we used to say that if we were screening for HAE, we would start with the C4. And as I mentioned earlier, if we can get all of these, it makes the diagnostic path shorter for patients and gets them on the treatment journey quicker. So again, these patterns will help differentiate between the types and guide our therapy selection. Now, I mentioned genetic testing, right? And this would be for confirming an HAE diagnosis, and again, maybe looking for that normal hereditary angioedema with normal C1 inhibitor, or in a patient who has inconclusive labs or maybe conflicting labs. It is not a frontline test for type 1 or type 2. It's obviously a very expensive test. I just showed you sort of the more simple testing that can be done and will offer a definitive diagnosis. So genetic panels may identify the pathogenic variants like factor 12 or SERPING1, and so therefore it can be very helpful. But again, if you're looking for HAE with normal, or you are not quite sure, that's when you would order genetic testing. We don't order this as a frontline test. What about family screening for hereditary angioedema? I mentioned the autosomal dominant pattern, and I also mentioned that about 25% of the time there can be no family history. As I mentioned, it can show up in childhood, it can show up in adolescence, it may not show up until adulthood, if at all. So the strong recommendations from both the World Allergy Organization and the European Allergy Asthma Society show a strong recommendation for screening family members of patients with HAE. Why is testing important? And they answer this by delayed diagnosis can increase morbidity, decrease that quality of life, and delay appropriate therapy. The first HAE attack may affect the airway, which can be life-threatening, or the abdomen. Unnecessary surgeries, as I mentioned earlier, even unnecessary CAT scans, right? So all first-degree relatives of patients with HAE should be screened. And there is 100% expert agreement on this from both the WAO and the EAACI, and it has an evidence level of D. What tests should be used? C1 inhibitor function, C1 inhibitor protein levels, and C4 plasma levels, as I mentioned. Again, reserving that genetic testing. And then what comes next? So upon diagnosis, on-demand therapy should be prescribed immediately and available for the first and or future attacks, even if no attacks have occurred yet. So again, we'd want to be thinking about grandparents, parents, siblings, children, and grandchildren. And this can be a lengthy conversation with families. I have had patients who want to get their whole family screened and understand this 100% expert agreement recommendation from our international guidelines. And then I've had some patients who are hesitant because they're nervous about having a diagnosis of a rare disease on one of their family members. So this can be quite a lengthy discussion, but it is 100% recommended. Early diagnosis through family screening can facilitate timely access to treatment and help prevent potentially life-threatening attacks. What about the HAE burden on caregivers? We know that having hereditary angioedema is very burdensome for the patient themselves, but it also carries a very large burden for caregivers and can lead to caregiver fatigue in some cases. We know that the burden of hereditary angioedema extends well beyond the acute attacks. Patients will live with the constant fear. When is the swelling attack going to occur? As I mentioned, these are unpredictable. They may have a prodrome, they may not. Is it going to happen right before an important presentation? Is it going to happen on my wedding day? This can severely impact work, school, daily activities, as well as, the mental health of these patients and their caregivers. There's a lot of emotional distress, anxiety. Patients can feel isolated, especially if those patients have frequent attacks or if they frequently have laryngeal involvement. When we know that anticipation of when that next attack is going to occur can lead to real anxiety and depression, and it can interfere in the advancement of a student's education or even the advancement of a career. Lifestyle modifications have to be discussed with patients in order to avoid triggers so that total disease burden of attack, wondering about an attack, that sort of constant vicious cycle can at least hopefully be interrupted or lessened to a large degree. Again, I mentioned caregiver burden, and here is some data that reviews that. Looking at the HAE-related tasks that are performed by caregivers, you can see that there are many things here. HAE, again, impacting beyond the patient, affecting their support networks. These caregivers will often take on the responsibility of monitoring the symptoms for their patient or their family member, managing the medications, handling emergency situations. I mentioned how stress can exacerbate and even cause, as a trigger, acute attacks of hereditary angioedema. So a caregiver is naturally going to want to take that stress away from their loved one. That can lead to stress in the caregiver themselves. And this data highlights caregiver-reported burdens, such as time spent coordinating that care, the emotional toil, limitations in their own work and their own social lives. So as we consider shared decision-making, it's vital to include caregiver perspectives in that discussion. So the angioedema control test, AECT, this is a validated patient-reported outcome tool that assesses disease control over the past 4 weeks. It's a nice objective way to really assess how your patient is doing with their HAE over the last 4 weeks. And there are 4 questions that you can see here. How often have you had angioedema? How much has your quality of life been affected by angioedema? How much has the unpredictability of your angioedema bothered you? And how well has your angioedema been controlled by your therapy? The scores are 0 to 4, very often to not at all. And the interpretation is a total score of less than 10 points indicates poorly controlled disease. And any score can help us gauge the frequency, the impact, the emotional burden, that perceived treatment effectiveness among patients, which is very important. If they don't feel that it's working, then we know that can also impact adherence. So again, a score below 10 indicates poorly controlled disease. And if somebody has a score like that, that's the time to reevaluate their management plan. Are they on the right treatment? Are they really minimizing their exposure to triggers? How is their stress? But I find that this tool is quick. It's a practical way to engage the patient as well, give them a little bit of buy-in to their own care, be part of the team. And it also helps us to quantify response to therapy over time. So trigger avoidance, I mentioned that, and it's certainly not an easy task, but identifying and avoiding known triggers can help and has been shown to help reduce attack frequency and improve quality of life in hereditary angioedema patients. So this includes managing stress, managing infections, managing trauma, even minimal trauma, banging your toe on the coffee table, for example, that can lead to an HAE attack. Certain medical procedures, getting a cavity filled at the dentist, getting a mole removed, any type of trauma, because all of that, each one individually and each one in combination, can lead to an acute attack. So it is important to discuss trigger avoidance as well as the discussion of the pharmacologic strategies, because these complement one another. Okay, so now we're going to shift gears and talk a little bit about the treatment of hereditary angioedema. And I can tell you that this has been a very interesting and dynamic journey since I started treating hereditary angioedema 20 years ago. So the general treatment strategies for HAE are listed here. So there's a three-pronged approach, as you can see on the slide: on-demand therapy for all patients, short-term prophylaxis for predictable triggers, and long-term prophylaxis to reduce overall attack burden. Again, shared decision-making is central. Patients need to understand their options. They and their caregiver's opinion need to be included, and they need to be able to participate actively in selecting the most suitable strategy for their lifestyle and for their particular disease severity, whether it's objective disease severity or even perceived. So on-demand therapy, we know, rapidly stops attacks at the onset before morbidity and mortality, and it's required for all patients to treat 2 or more attacks. Short-term prophylaxis, again, preventing attacks for those at increased risk with known triggers, dental procedure, medical procedure. This is also known as situational prophylaxis. And then long-term prophylaxis, again, reducing disease burden, decreasing overall attack frequency and attack severity, and again, individualized and engaging in shared decision-making. So key recommendations for treatment, according to the U.S. HAEA Medical Advisory Board, they had guidelines that were updated in 2020 for the management of hereditary angioedema, ensuring that all patients have access to on-demand therapy, treating all attacks, regardless of site or severity, and self-administration is preferred to give patients the freedom to live their life as normally as possible, despite living with hereditary angioedema. The reason I emphasize treating all attacks, regardless of site or severity, is because early on when we had treatment options for HAE, there were some drug shortages. And so the recommendations at that time were to save the medication for a severe attack. That is no longer the case. We treat all attacks. We recommend treating everyone, regardless of the site or severity. Provide prophylaxis. Again, another guideline from the U.S. HAEA Medical Advisory Board from 2020, using before known triggers. Long-term, individualized, again, using C1 inhibitor or lanadelumab or one of the others that we are going to review. Consider progestins, antifibrinolytics for HAE normal. There's limited evidence about this. We're going to discuss treatment options in a moment. And then individualizing and regularly adjusting and assessing management plans based on how patients are doing and by using that validated PRO that I reviewed earlier. Prioritizing patients' quality of life, adjusting first-line therapies based on their age, and avoiding exogenous estrogens, preferring C1 inhibitor as management during pregnancy and breastfeeding. We're going to discuss that a little bit more in detail as well. So this slide really is very important. It shows the history of the FDA approvals for hereditary angioedema. And, you know, I'm pretty honored and lucky that I've been able to be on this journey with hereditary angioedema patients and their families, because it has really been dynamic and quite exciting. Prior to 2008, we didn't have the best therapies. And the first approved C1 inhibitor human was approved in 2008 for HAE prophylaxis. And you can see along the timeline here, starting with that intravenous plasma-derived C1 inhibitor in 2008, the landscape has progressed dramatically to include subcutaneous, recombinant, monoclonal antibody, and even oral therapies for HAE. The development of all these novel therapies has really expanded patient choice, and it has allowed practitioners such as myself to give patients a tailored, less burdensome treatment option that's even more targeted. So this timeline really represents an amazing journey. So what about on-demand therapies for hereditary angioedema? So acute HAE attacks, again, require prompt on-demand treatment to reduce morbidity and the risk of a life-threatening reaction and possible asphyxiation. So the available on-demand treatments target different points in that bradykinin pathway. Yes, we got back to the bradykinin pathway. We remember it from our board exams, and now we're using it in real life. That's true translational medicine. So icatibant blocks the bradykinin B2 receptor, preventing bradykinin from causing vascular leakage. Ecallantine inhibits plasma kallikrein, reducing bradykinin production. And C1 inhibitor replacement, whether it's human or recombinant, restores deficient or dysfunctional C1 inhibitor, addressing that root cause of excessive kallikrein activation. So now we're just going to look a little bit more closely at the evidence that supports the use of these therapies and what helped get them to FDA approval. So this study that was published in 2009 by Craig and colleagues was one of the first studies to evaluate the on-demand treatment of hereditary angioedema. And as you can see here, the results demonstrate that symptom relief from HAE was achieved significantly faster with C1 inhibitor versus placebo. And it's really important to point out that this had a very favorable safety profile. No seroconversion, there was no transmission of any bloodborne viruses. And it's important to just remember that C1 inhibitor remains a trusted and widely used option for on-demand treatment of HAE. Looking at the Edema-3 trial, which was published in 2010, this is looking at on-demand treatment of hereditary angioedema with ecallantide. And the findings from this trial show that ecallantide effectively reduced symptom severity compared to placebo. And I think it's very important to point out the key endpoints, which are the TOS, or the treatment outcome score, and the MSCH, which is the mean symptom complex severity. So both of these key endpoints were superiorly treated with the ecallantide versus placebo. Again, it's important to note that this study revealed no deaths, no treatment-related SAEs, and there were no withdrawals owing to AEs in the study, supporting safety in clinical use. The FAST-3, which was published in 2011, was looking at icatibant for on-demand treatment of hereditary angioedema. And this looked at the median time to onset of symptom relief in the non-laryngeal intention to treat population. And icatibant provided faster symptom relief than placebo in those non-laryngeal HAE attacks. Injection site reactions were common, but they were mild and self-limiting. And it's just really concludes that icatibant offers a self-administered subcutaneous option, which is beneficial for that patient independence that I mentioned earlier when I was referring to those recommendations that had 100% agreement from our international societies. And the incidence of AEs was similar in both groups, which is also reassuring for icatibant. The CONFIDENT trial is looking at cebetralstat for the on-demand treatment of hereditary angioedema. This is an oral plasma kallikrein inhibitor for acute attacks. The study results, as are listed here, showed faster onset of symptom relief, significant reduction in attack severity, rapid complete resolution of attacks, as well as a favorable safety profile. There were no SAEs related to the trial agents reported in the CONFIDENT trial, and this was published in 2024. So the timeline that I showed you at the beginning, you can kind of see now the studies and when they occurred on that timeline, getting these therapeutic interventions FDA approval. What about prophylactic therapies for HAE? We're going to go into a little bit more detail here about this now. So this is, again, therapeutic advancement for long-term prevention. So this enables patients to have reduction in their attack frequency and severity even for the first time. So C1 inhibitor replacement therapy, again, restores baseline inhibitor levels. Lanadelumab is a monoclonal antibody inhibiting plasma kallikrein, and berotralstat is an oral kallikrein inhibitor for prophylaxis. Again, it's important to point out that the choice depends on that shared decision-making conversation, patient preference, caregiver preference being taken into account, frequency of attacks, route of administration, and all the other things that we have discussed. So this is the COMPACT trial, hereditary angioedema prophylaxis with subcutaneous C1 inhibitor. And these results demonstrated a significant reduction in attack frequency with subcutaneous C1 inhibitor versus placebo. Local site reactions were the most common AEs, but again, these were generally mild. And it's really important to think about how convenient a subcutaneous administration for ongoing prevention can be for these patients, especially when we consider the burden of disease that we reviewed for hereditary angioedema. HELP is a study looking at lanadelumab for HAE prophylaxis, and this was published in 2018. And the findings here, as you can see, indicate substantial reductions in attack rates with lanadelumab and attack severity, as you can see there as well. Injection site reactions and dizziness were more frequent with lanadelumab, but they were considered manageable. So lanadelumab offers a targeted biologic option with infrequent dosing, which may be suitable for some patients after that shared decision-making conversation. APEX-2 is the study from 2021 that confirmed the efficacy of daily oral berotralstat for preventing hereditary angioedema attacks. Common AEs here included mild GI symptoms, but importantly, and I think it's very important to mention this, no serious treatment-related AEs were observed. But again, abdominal pain, vomiting, diarrhea were reported. Again, this is an oral medication, so it wasn't completely unexpected. No drug-related serious TEAEs occurred, and in some patients, the benefit of an oral prophylactic option may be advisable. A lot of patients may have needle phobia, for example. Vanguard was looking at the efficacy of garadacimab for HAE prevention. And you can see here, looking at the monthly attacks during the 6-month treatment period, as well as the reduction in HAE attack rate per month, that garadacimab, which is a monoclonal antibody targeting factor XIIa, that upstream trigger that we looked at in the bradykinin cascade on an earlier slide, there were fewer monthly attacks over that 6-month study period. There was good tolerability, and factor XIIa inhibition did not increase bleeding risk, which was a concern when you think about the pathways. This alleviated a major concern in that this did not occur in the study. And it's important to note that garadacimab does have a novel mechanism of action. It's the first one that does block factor XIIa. What about recently approved and emerging therapies? So we went through the timeline, and that timeline keeps marching forward because very recently, as of August 21st of this year, donidalorsen has been FDA approved. This is an antisense oligonucleotide which reduces the expression of prekallikrein. OASIS HAE was the phase 3 trial looking at this for long-term prophylaxis. And again, it got approval in August of this year. There are some emerging therapies. There's deucrictibant and NTLA-2002. Deucrictibant is an oral bradykinin B2 receptor antagonist. Phase 3 trials include RAPID-E3, Chapter 3, and Chapter 4. RAPID-E3 is acute. The others are long-term prophylaxis, and the phase 3 trials are currently recruiting. NTLA-2002 is in vivo CRISPR gene editing of kallikrein B1. The study is called HALO, and it is for long-term prophylaxis, one-time gene editing. Enrollment completion for H2 is 2025, and potential BLA in H2 2026, with a potential launch in 2027. So we've certainly come a long way. So again, thinking about that evolving treatment and what we already have available to us, we have the C1 inhibitor, whether it's human or recombinant, for both on-demand and prophylaxis treatment of hereditary angioedema. We have berotralstat, first oral prophylactic agent, ecallantide and icatibant for on-demand use, lanadelumab, monoclonal antibody used for long-term prophylaxis. And the treatment really has shifted focus to include not only on-demand emergency care, but also that proactive management, improving the quality of life, all of the things we discuss with our patients, not only about their pharmaceutical the therapies, but also lifestyle management. But a number of novel therapies, again, with that potential to provide additional options. We reviewed those earlier, not only for on-demand, but also for prophylactic treatment of HAE, are currently undergoing investigation, and several are within the works that aren't even listed. And it's really exciting, this ongoing development. There's so much promise for improving the life of patients with HAE and improving their outcomes, expanding their personalized treatment strategies, and really potentially transforming the HAE management overall. OASIS HAE, this was published in the New England Journal of Medicine in 2024, looking at the efficacy of donidalorsen in HAE. Again, that is our antisense oligonucleotide targeting kallikrein mRNA. Key findings: substantial reduction in attack rate. High percentage of patients experienced reduced frequency of attacks and a favorable safety profile. Most AEs that were reported were mild. It is a subcutaneous injection, and again, may be preferable for patients who prefer less frequent injections. Chapter 1, looking at deucrictibant for prevention of HAE attacks, phase 2. Again, the small molecule kallikrein inhibitor. You can see here overall monthly attack rate, the severity of moderate and severe attacks, as well as on-demand treated attacks, were all reduced. TEAEs were reported as mild, and there were no serious events. There were no discontinuations reported to date. Early results here, I think, are promising. Development is ongoing. Again, a very active landscape for HAE treatment. CRISPR-Cas9 in vivo gene editing of kallikrein B1 for hereditary angioedema. So a small-scale trial using that CRISPR gene editing, targeting that gene, again, KLKB1, encoding prekallikrein. So what we know so far is that a single dose led to dose-dependent reductions in kallikrein levels, fewer HAE attacks across all dose levels, and there were no serious SAEs observed as of yet. In exploratory analysis, reductions in the number of angio attacks per month were also observed at all dose levels. So this is really important because it is the first trial involving an in vivo gene editing approach in HAE, which really has potential to change the landscape and lay the groundwork for a functional cure, possibly in these patients. So what about some practical recommendations? I've kind of hinted at this along the way throughout this presentation. It's just very important to review this one more time. Individualizing treatment plans based on attack frequency, severity, patient preferences, providing all patients with access to effective on-demand treatment for those acute attacks, considering long-term prophylaxis for patients with frequent or severe attacks, and recommending short-term or situational prophylaxis before procedures that have been known to trigger attacks in a patient prior, such as dental. Encouraging self-administration, the more freedom a patient has, the better. This improves their quality of life, as well as reducing any delays in treatment. I think it's important to remember and to review the shared decision-making 3D model in HAE management. Really, it's discuss, discover, and decide. Talking with your patients and their caregivers, their family members, about all the options, all the alternatives, making sure that you and your patient and caregivers are aligned with the goals. making sure that their preferences are informed, that they understand the risks and benefits and the data for the medications that you're reviewing with them. Exploring those patients' needs and goals, cultural differences, religious differences, needle phobia. There's so many things that can come into this, and acknowledging those options and that may or may not fit a particular patient's needs and goals, and then together deciding what therapeutic option may be best based on validated information. This model really just supports patient engagement, treatment adherence, and satisfaction overall. As you can see here, that expanded model of shared decision-making, accounting for patient-centered care, social determinants of health, and health equity are very important, again, for optimal patient outcomes, as well as health equity throughout. Again, assessing those individual barriers between patients. They may be very different, and proactively connecting patients with resources, whether it's the HAEA for Educational Hereditary Angioedema Association, whether it's places to get financial support, whether it's patient advocacy groups. All of this can help your patients, but that traditional shared decision making model should be expanded to include all of this, again, to optimize patient outcomes with hereditary angioedema. So the HAE Patient Action Plan is really important. This plan needs to be clear, concise, and written down. Now, I'm a little, seasoned. As I said, I've been treating HAE for over 20 years. So when I say written, I think about a pen and ink, but it also could be as simple as having it on a phone. There is an app offered by the HAEA, which also offers this, but a clear plan that they can show to any provider that they may come into contact with, such as at an emergency room or urgent care, because some of those providers may not be as well versed on HAE and may be able to use that action plan to make sure that the patient gets prompt treatment to avoid any untoward outcomes that they may easily avoid. So again, that written plan that not only describes the medications that they are taking for prophylaxis, but any on-demand therapies, when to seek emergency care for themselves, for their caregivers, or if heaven forbid, a patient has an attack and passes out and somebody else finds them, how to administer the medication. Again, clear, concise, and easy instructions. Planning for travel. We want our patients to be able to be free to travel, whether it's for work or leisure. So we want that action plan to be clear, concise, and they should know what emergency rooms may be nearby, what healthcare providers may be able to help. And again, remembering the signs and symptoms of HAE, not only for most patients, but for your patient specifically. Again, a well-structured action plan can help improve patient confidence, timely treatment, and overall help patient outcomes. So now I'm very excited to welcome Dr. James to this discussion so that she can present a real-world patient case for us. Dr. James?
Sounds great. So this is an actual patient, a 16-year-old female who presents with recurrent abdominal swelling. It's happening on average 3 to 4 times per month and varies from mild to quite severe. Symptoms are typically resolving within 1 to 2 days. She has had some lip swelling as well. It hasn't accompanied the abdominal swelling. She denies any history of rash or itching. It has been severe enough that she has been in the emergency room twice. For that first visit, she presented with abdominal cramping and diarrhea. She had CT imaging of her abdomen, which showed thickening of the terminal ileum and her right colon. Due to that, it was initially thought her symptoms were related to infectious colitis, and she was treated with IV fluids, felt somewhat better, and was able to go home. However, 2 months later, she returned with similar symptoms, abdominal pain and swelling, but this time she did not have diarrhea. She again had imaging due to that prior history, and at that time it showed persistent but improved thickening of the terminal ileum and right colon. She was treated with pain medications and discharged with plans to see GI for follow-up and possibly a colonoscopy. She had no new medications prior to the onset of the symptoms. Next slide. In terms of her medical history, she really had no other medical conditions and fortunately had had no surgeries. As Dr. O'Connor outlined earlier, unfortunately, a lot of these patients, before they are diagnosed, undergo repeat exploratory abdominal surgeries, but she had not. In terms of medication, she was not on anything at the time. Her hospitalization history was only relevant for the 2 ED visits for the abdominal pain. Next slide. So moving on to our first question, which of the following aspects of the patient's history would lead you to suspect the presence of hereditary angioedema? And you should now be able to select from the choices. We have A, location of swelling during attacks, B, pain associated with attacks, C, absence of rash or itching, and finally D, CT findings.
Give them a second to answer. Just waiting for the poll. There we go.
Okay, so on our poll, it looks like a lot of you selected choice A, and that really is a key history for this patient. Hereditary angioedema really should be suspected with recurrent swelling of the abdomen. Other common sites of swelling include face, extremities, and the upper airway. Choice B and C, both of those also can support this. Pain is often accompanying the swelling, and notably, these patients should not have hives or itching. Choice D also supports this. Abdominal ultrasound can be used as well to really help identify that the pain is coming from angioedema or swelling of the intestines. Dr. O'Connor, any additional thoughts?
I just think it's important when we think about the radiograph findings because, I have had 1 or 2 patients where the only objective finding was some edema in the bowel wall. And it was really a savvy emergency department physician who did that twice, made sure that the imaging showed that. But it's hard to find that, and it's hard for emergency room physicians to really know about HAE since it is so rare. And I do think that the absence of itching is really important because patients always associate rashes with itching and swelling with itching. So if they don't have it, I just think that's important, like in your patient. Do you find, Dr. James, that most of your patients that you see don't have much of a medical history? Like she didn't have any medication, she didn't have any surgery, I find in my patients are typically a little more complicated. So I was just wondering.
Yes, no, and I would agree. It's usually not that straightforward. Being 16 years old, I think, does help.
I agree. Absolutely.
Yes,
okay, wonderful.
Exactly. Okay, so moving on with history. She's a non-smoker. She does have 2 dogs in the home, but none of the episodes have seemed associated with exposure or increased exposure to her dogs. Also, no other environmental factors. Notably, she has a very strong family history with both mom and maternal grandmother being diagnosed with hereditary angioedema type 1. What's interesting though, mom describes hers as always being episodes of extremity swelling. So she did not have abdominal swelling. So our patient, despite this family history, has not yet been screened for hereditary angioedema. Next slide. Review of systems is otherwise negative. An exam, noting this is during a time between attacks, not during an attack, normal vital signs. Next slide. No visible swelling of her face or extremities, really largely unremarkable. Next slide. Her abdomen is soft, non-tender, non-distended. During presentation at the emergency room, her exam was notable for right lower quadrant tenderness. Interestingly, no abdominal distension was noted, but I think this is where it's important to point out for most patients, it's really quite impressive abdominal distension, especially when you have a picture or you've seen the patient between episodes. But for someone presenting to an emergency room or a provider who's unfamiliar with their baseline, they may not really appreciate how severe the distension can be or is at the time. Next slide. Okay, so going on to our next question. What type of testing would you order for this patient? A, C4, C1 inhibitor level and function. B, gene genetic testing. C, allergy skin testing. We'll give some time for responses. Fabulous. 90% of you went with choice A, which I would agree. Your initial testing in a patient with suspected hereditary angioedema should include a C4 level, C1 inhibitor level, as well as C1 inhibitor function. B, gene, also known as the Hereditary Angioedema Focused Gene Panel, is a very helpful genetic test, but should not be first line. Indications for this testing would be a strong history concerning for hereditary angioedema with normal complement levels. So you're really thinking that HAE with normal C1 inhibitor. C, allergy skin testing may be indicated, but in our patient's history, we really didn't have any environmental or allergy trigger concerns. So definitely a consideration, but not for our patient today.
I think it's interesting you mentioned that abdominal distension because I've seen all kinds of different variations of that, from one like your patient that maybe didn't really have any appreciable to male patients that look like they're 9 months pregnant, right? So a man would walk into an emergency room, have a huge belly like that. They often think of liver disease, right?
Yes.
But it can be because of that bowel wall edema. And so whenever you see a patient like that, you don't forget it. That's the one thing I would say. The other thing I think it's important is that family history, right? We don't always have that family history. And so I think that maybe could cloud the picture when we don't know the family history. In this case, we know that 2 of the family members had it. So really, A seems to be the best choice as well, because why you wouldn't really need a genetic test if those come back and show us the answer, right?
Correct.
Yeah.
Yes.
And then as far as the allergy skin testing is concerned, I didn't hear any history of allergic rhinitis or asthma or eczema, anything that would really make me think to go down that road either. So I think that's wonderful. Have you ordered much genetic testing, Dr. James, for these patients?
Not so much for this. Interestingly, I had quite a few that I think met criteria for HAE with normal C1, but at the time we didn't have it available.
Yeah.
So looking forward to when we can utilize that in the future.
Again, this evolving landscape for hereditary angioedema, not only with treatment, but also with diagnostics. It's so exciting.
Very true. Okay. So we did order those tests for our patient, and as you can see, C4 protein level was 11, which is low, C1 inhibitor level at 7, also low, and lastly, C1 inhibitor function at 18%, which was low. So based on this, all were repeated and showed similar results.
Okay.
Next slide. So based on the patient's lab results, what would be your diagnosis? A, HAE type 1, B, HAE type 2, C, HAE with normal C1 inhibitor, or lastly, D, allergic or idiopathic angioedema. And you should now be able to enter your responses. Okay, fabulous. The majority of you did go with A, HAE type 1, and I would agree with that answer based on the fact that our patient had low C4 as well as low C1 inhibitor and function. Choice B, HAE type 2, in that situation, we would expect that the patient would again have low C4 and C1 inhibitor function, but the C1 inhibitor level itself would be normal or elevated. Choice C and D, both of those would show normal complement levels. And in our case, the patient had low levels for all three, so would not be either of those. But in those situations, if you do see normal complement levels, you can try to sort those out potentially by a trial of antihistamines, high-dose antihistamines. That may help you determine if the patient has allergic angioedema. And then again, for the HAE normal C1 inhibitor, if you're suspecting that, you would look at the GNA genetic testing. Anything to add?
I would just say, again, that distinction is so important. And I think in a patient like this, who's 16 years old, she has the family history. It seems like a slam dunk, right? But not necessarily. And we have to remember that as exciting and dynamic as the treatment landscape is, we wouldn't want to put her on any of the treatments without a definitive diagnosis. And I think that's important to point out as well.
Okay, next slide. Okay, so now we're looking at treatment options. And for our patient with a frequency 3 to 4 times a month, we're definitely wanting to consider prophylaxis. So which of the following would you prescribe for prophylaxis? Choices are A, a C1 inhibitor, B, danazol, C, lanadelumab, or D, berotralstat. And you should be able to enter your selection.
So we have our monoclonal antibody, we have our oral, we have a steroid, and we've got our C1 inhibitor.
And definitely, again, the focus, as so nicely outlined by Dr. O'Connor, was shared decision-making because there are multiple choices. So the majority of you went with choice A, C1 inhibitor, although D and C were second choices. No one selected, which was lanadelumab and berotralstat. No one selected danazol. So we'll go through those choices. So for A, C1 inhibitor, that has both IV and subcutaneous options. Sub-Q given twice weekly, has more consistent plasma levels, easier administration than IV. Local site reactions would be your main consideration there. Danazol is an androgen, actually a very effective therapy, but looking at our patient who's a 16-year-old female, likely not a great choice. Least problematic in adult males, but really should be avoided in growing children and women who are pregnant or breastfeeding. For choice C, lanadelumab, that's going to be a subcutaneous injection every 2 weeks, and then after 6 months, may be able to be lengthened to every 4 weeks. So the main advantage of that one for our patient would be infrequent dosing, does have some side effects of injection site reactions, upper respiratory tract infections. And lastly, berotralstat may be a great option if our patient is needle phobic, wants an oral therapy, does again have those mild GI side effects. So lots of good choices here. I think the important thing again is discussing those with the patient, seeing what will be the best fit for them personally, and just remembering growing children and females want to be very cautious with the androgens.
Yeah, and I think there's a couple of points here that, with danazol, I honestly do not have any patients on danazol anymore because of the considerations that you mentioned. And also, the hepatotoxicity and the increased risk for hepatocellular carcinoma. I did have an HAE patient who had been in all of the clinical trials and had been on danazol for years and years and years prior to us having these FDA-approved therapies. And unfortunately, he did develop some of those symptoms. So I say that very confidently that danazol works great, but really thinking about those side effects like you mentioned. And then for the berotralstat, I think the mild GI side effects would make that a consideration just because her symptoms are mostly abdominal, but she didn't have nausea every time. So it might be an option for her, right? And then I guess the only other thought I have is her mom and her grandma both have hereditary angioedema. So I would think about probing them and what treatments that they are on and what are their feelings about the treatments. We mentioned talking to caregivers and inviting them to the shared decision-making conversation, especially for a 16-year-old. But a lot of patients think that, oh, well, it worked for my mom, it'll work for me. And that's not necessarily true, but in some patients it is. So I'm sure that was an interesting conversation, and I'm looking forward to hearing what happened there.
Sounds great. So going on. So it's important to remember, oh, sorry, back one.
That's my fault.
It's important to remember for patients, even if on prophylaxis, you need to make sure they have an on-demand therapy as well for any breakthrough symptoms. And so for our patient, what type of on-demand treatment would we prescribe? Choices are A, C1 inhibitor, B, icatibant, C, ecallantide, or D, sebetralstat. And again, your choices should appear. Okay, so lots of choices across the board here for our patient. So looking at choice A, C1 inhibitor, I think just remembering that's primarily going to be IV and can be given at home, but does require IV access. So just seeing that as an option. B, icatibant will have the advantage of being subcutaneous, but do have to remember there are mild injection site reactions that can be seen. C, ecallantide, and that's again subcutaneous, does have the excellent safety profile, but due to the possible risk of anaphylaxis, has to either be given in a medical facility or a trained nurse at home. And interestingly, that was not a selection in our patient response. And that is probably that limiting factor in quality of life that Dr. O'Connor mentioned, where that therapy is a little more limited at this time. And then lastly, choice D, sebetralstat. Great option, again, in that it's oral for the patient who may want to avoid needles, but have to consider in this one, and does have, I should mention, also a great and fast onset of relief, but do have to be cautious not to be used in patients with severe hepatic impairment, fortunately not a problem in our patient, or those on other medications that can interfere through that cytochrome 3A4. So just making sure patients are aware of that if that is a consideration. So lots of great options there, and honestly can be sometimes hard to know which will be the best for the patient. Dr. O'Connor, any additional thoughts?
Oh, I'd say there is sometimes with options that you have multiple, sometimes that shared decision making helps everyone involved, including us, right?
Mm-hmm.
I know that we are getting a little tight on time, so I'm going to move forward and let you discuss the treatment plan and the discussion you had with this family.
Perfect. So we did use shared decision making, and the patient decided, as we reviewed the options, to start with C1 inhibitor concentrate for their prophylaxis. And then in terms of on-demand therapy, icatibant. Now, notably, that is off-label, not FDA approved. Some of that did come from what had worked well, as you mentioned, for mom in the past. But that is kind of where she started. And next slide. She really overall did great, but did start to have some breakthrough abdominal and one episode of throat swelling. When we looked at timing, we realized that was due to her being late or missing a prophylaxis dose. So we really worked on adherence and the importance. And once she saw that pattern, she's done great and has been able to stay on top of things and not had any more breakthrough symptoms. Next slide.
I think what I would say there is that just highlights that importance of that follow-up and reiterating that shared decision making and reassessing as you did, and obviously did well since she's doing much better.
Exactly. And I will say we did mention the importance of genetic screening. Excuse me, not genetic screening. First line hereditary angioedema screening for any children. And I think she's a great example where she had a strong family history, but it just was never done. And so the importance of that going forward.
Yeah, absolutely. Especially with the increased availability of that testing, right? Yeah. Okay, so we're just going to summarize the key points and then be happy to take some questions. I know we're running tight on time, but I think it is important to summarize that, as Dr. James mentioned, early diagnosis is essential to ensure appropriate treatment and improve disease outcomes for patients with HAE, like our 16-year-old patient. First-line diagnostics include C4, C1 inhibitor, antigenic level, and C1 inhibitor function. And if those results are normal, but HAE is still suspected, considering that genetic testing for HAE with normal C1 inhibitor. Treatment should target reduction of disease impact on the patient and the caregivers, and on-demand therapy for all patients, and then prophylaxis as determined. And then the HAE treatment landscape, as I've mentioned, and diagnosis continues to evolve. There are so many new options, increasing options for on-demand treatment of those acute attacks and prophylaxis, and now the gene therapy. It just continues to evolve, but the HAE management really needs to be personalized based on your individual patient's attack frequency, severity, and patient preferences. So now we will just let you know that this is how you can claim credit. And I'll leave this up, but we're happy to take any questions and at this time.
There is one question in the Q&A box. I'm not sure if you're able to see it. If not, I can read it out loud for you.
I can't see it. Dr. James, can you?
I cannot.
Okay.
So the question says, what would you suggest to a patient with HAE who is planning to become pregnant?
Oh, okay. I think I have a slide on this. If you can give me one moment, if you'll indulge me for 1 second. There we go. Okay, so Dr. James, your patient's 16-year-old female. This is right up your alley. You'll have to talk to her
So
about
we
this
did
eventually.
discuss that with the patient, that the only preferred options at this time for both prophylaxis and on-demand are going to be the C1 inhibitor treatments. And so as she is nearing that choice or making that decision to start a family, that those would be what she would want to transition to for her on-demand therapy. So yes, definitely important, I think, to discuss with patients and to be a consideration in that shared decision making.
And when you were talking with your patient about this discussion, did mom and grandma say anything about their journey compared to hers? Since we didn't have all these treatments and diagnostic options.
Right. Yeah, I think overall mom was a little bit more mild in nature.
Mm-hmm.
And so, but yeah, I think it was just that the options were a little overwhelming and that there were so many choices to select from. So I think, yeah, just in that being the main change in the treatment options, just so much more now that we can choose from.
Absolutely. I don't see any other questions, but I couldn't see the original one. Are there any additional questions, Integrity?
Not at this time, no.
Okay, well then I would like to thank Dr. James for an excellent presentation, and thank you so much for having this conversation with me. And you can claim CME credit here, just returning to that event page. And there is a post-test and evaluation, and then a statement of credit will be issued and immediately available for download following your completion of the post-test and evaluation. So thank you again, Dr. James, and thank you all for your participation. Have a great evening.
Thank you. Good night.